Hi, everyone. Welcome to the SAEM Research Learning Series course online lecture titled Challenges in Ultrasound-Based Research. As we begin today, please write down and save any questions you may have for the end of the presentation. You can either enter them in the chat box or unmute yourself during the Q&A portion of the lecture. This presentation is being recorded and will be available shortly following today's session. And now it is my pleasure to introduce to you Dr. Mark Favot. Dr. Favot is the Chief of the Section of Emergency US at the WSU-SOM Department of Emergency Medicine. He also runs a core echocardiology lab at the Integrative Biosciences Center at Wayne State. His research interest is in advanced echocardiography at the point of care and in acute heart failure. He's originally from Canada and maintains dual citizenship, which permits him to wear the hat of whatever nationality it is convenient for him to wear at the moment. Dr. Favot, I will now turn it over to you.
Alrighty. Thanks a lot, John. Thanks to James Paxson as well for inviting me to provide some content for this SAEM research series. And so today we're going to talk about lessons in point of care ultrasound research. And fortunately for you, I've had the opportunity to learn a lot of these lessons the hard way. And this will hopefully prevent you from having to learn them the hard way as well. Whenever somebody asks me about point of care ultrasound research and how to prepare to engage in point of care ultrasound research, I like to take them to this clip and this little pearl from Mr. T. So let's just watch this together.
What's your prediction for the fight? Prediction? Yes, prediction. Pain. What's your...
So the reason that Mr. T is so accurate in that prediction as it pertains to point of care ultrasound is that point of care ultrasound is this very unique application that sort of fits nicely in the middle of a lot of different things. It has like a huge Venn diagram that overlaps with a lot of different areas in the house of medicine, but doesn't really neatly fall into any one area. And so it can make the job of the person starting out in research in point of care ultrasound really hard. And in point of care ultrasound, we have a lot of novel, interesting ideas, but because of the uniqueness of it, we tend to be a little bit low on the quality side of things as it comes to research. And so hopefully the primary objective will be achieved today, and we can work on some secondary objectives, namely helping you to learn from my mistakes. I made a lot of mistakes along the way. I got put into a role straight out of fellowship that I probably wasn't really prepared for. And so I made a lot of mistakes. And so hopefully we can help you make fewer mistakes and shorten your learning curve to proficiency as a point of care ultrasound researcher. I think some of the things that we really need to focus on are the first 2 points here of creating a good study team, and then going on to ask a study question that our team is well suited to answer. We can't really accomplish those things in isolation or in silos. And so we really need to kind of work on those things together. And so a lot of today's lecture is going to hopefully share some examples and give you some tools that can help you create synergy between the team and the question that you're asking. And then some of the other things that we're going to talk about are how to talk to the various stakeholders and different audiences. Really important to remember that we're scientists here, we're not evangelists. And in point of care ultrasound, we tend to take on an evangelistic approach very often just because we get so passionate and so excited about it. And if we learned anything about data and interpretation over the last 9 months of the COVID pandemic, we should have at least learned that intelligent, well-meaning scientists can look at a set of data and interpret it 2 different ways. And that doesn't mean it's us against them. It's simply an opportunity for collaboration. So who am I? John gave a brief little introduction, but for those of you who don't know me, my interests outside of medicine are my family, golf architecture, and gambling, typically in that order. I'm from Windsor, which some people, Journey at least, might refer to as South Detroit. The only people that think South Detroit means Windsor are people from Windsor. It doesn't actually mean Windsor. This was like in an article in Rolling Stone years ago. He wasn't actually referring to Windsor. He had no idea that there was no South in Detroit, that south of Detroit is literally the water, followed by Windsor. That's where I come from. I went to Washington, D.C. and George Washington for medical school. Then I came back to Detroit for residency. And in fact, my parents' hospital, or my parents' house, the one where I grew up, was closer to the hospital than my house when I was in residency training. So Windsor really is just this suburb of Detroit that happens to have an international border in between. Following residency, I completed fellowship and then immediately took the leading the ultrasound programs at Sinai Grace Hospital and Wayne State University. And so I was put into this role that I certainly thought I was ready for. But looking back over the years, it was clear that I had a lot to learn. And fortunately, I had a lot of good mentors, a lot of patient leaders that helped me to learn on the job. But as Mr. T taught me, it was not without a lot of pain. So the first thing we're going to discuss is how to ask a really good POCUS research question. And so if you're doing any research, even if you haven't done any research, but you've read anything about research, hopefully you're familiar with PICO. We're going to talk about it a little bit as it pertains to ultrasound. We'll delve into some of the problems with case reports as it pertains to point of care ultrasound. Everybody in point of care ultrasound seems to be seeking out the next original protocol or the next frontier, the new application. That is what kind of is sexy about point of care ultrasound, is at least for years, there was a lot of uncharted waters, and people were publishing things seemingly every week on these new modalities. And so a lot of people are really interested in that, but I would encourage the burgeoning point of care ultrasound researcher that they may want to focus on some of the old stuff and improving some of the old stuff. And we'll talk about some strategies as to how we can start to do that in the future. One of the original study subtypes in point of care ultrasound was this comparison to comprehensive imaging. And so we'll discuss this and why it certainly had a role in the establishment of us as a subspecialty in the House of Medicine, but why we may want to move on to different avenues. A lot of ultrasound is just simply imaging from a different lens. And so it's really important to understand what constitutes a diagnostic accuracy study. How do we go about developing a study where we can derive the characteristics of a test, and then how do we go about validating that? Probably the most unique aspect of point of care ultrasound in the House of Medicine and the imaging side of things is the ability to perform serial exams. This is something that's just simply not done with other modalities. You don't see patients with stroke go back to the MRI scanner every 3 hours for a repeat MRI as their clinical condition or their hemodynamics change. And that's something that's very feasible and very much reality with point of care ultrasound. So we'll talk about that and some of the challenges that it presents. Probably the holy grail of most biomedical research is outcomes-oriented research. And this is probably an area where we've kind of dropped the ball or at least been lagging behind in point of care ultrasound because quite honestly, it's very hard. So we'll talk about some of the challenges with that and what we can do to maybe bridge some of the shortcomings inherent with point of care ultrasound, looking at prognostication and patient satisfaction. Those are terms that speak to people outside of the teeny tent of point of care ultrasound next to the House of Medicine. We'll give a little bit of time to what I call the fallacy of feasibility. Feasibility used to be a really easy way to get something published in a biomedical journal, but it's becoming harder, and we'll talk about why. Medical education is going to be a small focus, but with the explosion of different populations of learners that have intense interest in point of care ultrasound, this has provided us in the point of care ultrasound world a lot of opportunities. So if we're going to talk about research, like I said, we really do need to talk about PICO. So from an ultrasound standpoint, how this works, if we can just kind of think about some of these diagnostic accuracy studies or diagnostic comparison studies, we have a group of patients. Typically in point of care ultrasound, the patients will be patients who have a symptom or a set of symptoms or in whom there's a clinical concern for a condition. The eye is the intervention or the exposure, which will almost always be the point of care ultrasound exam itself. If we're doing a diagnostic accuracy study, the comparison is going to be some sort of reference standard. So the comparison here may be angiography if we're looking to diagnose obstructive coronary artery disease, or the comparison could be clinical follow-up and or laparotomy findings if we're looking to diagnose hemoperitoneum in trauma patients. And then the outcome is the outcome. So before we actually go about designing the study, we need to know what the outcome is that we're looking for. What would constitute positive and negative? And then what is the likelihood of said outcome being achieved? If the outcome is, death from X, Y, or Z condition, it's really helpful when you're designing a study, not only to know the outcome, but to know the probability. When we get into the discussions that we're going to have with our biostatisticians, for them to do their job to the best of their ability, it's really up to the content experts to know likelihoods of outcomes. And it doesn't have to be perfect. If you think that if you give an estimate of patient with presenting condition X, Y, or Z dying as 5%, and it turns out to be 10% in your study population, that's not a death now. That just means that the statistics might need to be adjusted a little bit because you underestimated the likelihood of the outcome. It's actually probably helpful. In a estimate on one side or the other, it's probably helpful to have underestimated as opposed to overestimated. So that's PICO. If we're working our way through the research totem pole, at the bottom is going to be case reports. And so case reports in point of care ultrasound used to be really easy. They used to be like low hanging fruit. Anybody could publish one of these anytime they wanted to. It's gotten a lot harder. And I use this as an example. This is a former colleague of mine. And he called me one day. I was driving home from work, or I was driving to work, and he happened to be driving home from work. And he called me and he was excited. He was telling me about this case. And so what had gone on was this 40 or 50-year-old dialysis patient had developed a fever and shoulder pain. And they literally had no range of motion of their shoulder whatsoever. And he had done an ultrasound exam and found a sizable effusion inside the shoulder joint. Given that it was Friday at 5 o'clock, he was having a hard time getting the specialist to come in. And the specialist was using, a lot of the old tricks of, wow, this patient's on dialysis, they're septic, they're medically ill. Like, I don't feel comfortable taking them to the OR, blah, 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 blah. So my colleague set up a bedside washout of this patient's shoulder where he put two 16-gauge angiocats into the shoulder joint and washed out the shoulder with 4 liters of sterile water. And after the washout, the patient suddenly had regained range of motion of the shoulder. And then ultimately the patient never went to the OR at the end of this case anyway. And so he's telling me about this on the phone. And I said, Leo, this is gold. Like, you're going to submit this to New England Journal, right? This is great. And he's like, yeah, I don't know. I was pushing him really hard. I figured this would be quick, painless. He'd get this published immediately. Well, about 10 months later, and I'd say 25 revisions later, he finally got it published, and he just wanted to light the whole thing on fire at the end. And so it's really tricky to get an ultrasound case report published these days. It's a lot harder than it used to be. This is kind of what everybody, at least all of the young ultrasound people that I talk to, get really excited about, is coming up with something brand new that they can put their name on, or that they can come up with a neat little acronym, and it becomes the next big thing that people are talking about in our fairly small community. And so if you're not familiar with this one, this is the Raptor block. This is a supraclavicular plexus block. An infraclavicular plexus block coming from the supraclavicular retroclavicular approach. It sounds crazy. It sort of looks crazy, but it's really not. So the whole thing here is that they insert the needle behind the clavicle, and they bravely advance it blindly behind this bone that shadows out all the sound. And then the needle magically emerges on the other side, right at the infraclavicular brachial plexus, and you block it and you have great anesthesia. This is one of a very small number of studies that has been published in the last few years that falls under this new original POCUS application. And these studies are more likely to come at serendipitously. This is not something that this team had intended to publish. The lead author on this is actually a physician assistant. And so this is something that was just kind of done in the ER out of, I wouldn't say necessity, but it was a novel approach to a different block. And suddenly they did it in a few patients and they wrote it up. And so that tends to be how these things are arrived at. This is not like the research focus of a POCUS division. These tend to happen accidentally. What I think we can really focus on in the next decade is improving on some of the old stuff. And I say old stuff, and it's really not that old, but it's old relative to the specialty. You have to remember that as a point of care ultrasound, as a specialty, we're only about 20 years old. And so a lot of studies done in the first decade of the 21st century were of this sort of subtype. And so this subtype is the kind of look what we can do. We can do it just about as well as radiology. And so this one was a detection of cholecystitis. It was from Chris Fox's group at UC Irvine. I put the table 2 statistics up there for you to regard. This is pretty good. The negative likelihood ratio is favorable compared to radiology. And then what happened was these things got done in all these different modalities. So they got done in renal ultrasound, gallbladder ultrasound, aorta, echo, and then everybody just stopped because, well, that was done. That box was checked. We sort of proved that we're as good as radiology. Let's move on. The problem was what was really proved was that the people at this institution with that institution's equipment on those patients did as well as radiology at that institution. And in the natural evolution of diagnostic imaging research, the next thing that should be done is a multi-center study where you're using patients from multiple different geographic areas. You're using multiple sets of equipment. You have a much larger population, so you're able to detect much smaller differences. Because as you see here, this was not a ton of patients and no real difference was detected. But maybe a difference does exist. We just didn't study it in enough patients to actually detect it. And so unfortunately, that never really did happen for a lot of point of care ultrasound. And one of the ways we can maybe push this forward in the future is in development of some of these regional networks of point of care ultrasound folks that are actually happening and really kind of just moving in slow motion right now. But this is the area of opportunity that's really ripe for point of care ultrasound research. I'm a part of the Great Lakes Ultrasound Consortium, which encompasses the medical centers in the, as you would guess, Great Lakes region. I am the research director for the research committee, and we have to this date produced 1 manuscript. So, I'm talking the talk, but we're not really walking the walk. I would argue that COVID had particularly poor timing for our group as we were on the precipice of starting our first project. But be that as it may, this is my call to everybody around the country to start thinking about forming these ultrasound groups and consortiums that can maybe take some of the old stuff that was done in the prior decade and push it forward. So I'm going to talk a little bit here about diagnostic testing and comparison studies. And so to start, you should familiarize yourself with this series of reporting endpoints called the STARD guidelines. This is not a brief document that has 30 different reporting criteria for studies of diagnostic testing. And so some of the things that they include are adequate description of the index test, which in this case will be point of care ultrasound, and the reference test, which could be anything. Usually it's going to be radiology based, so that the study can be replicated at a remote site by people that were never originally involved. You need to comment and report on how your missing data is handled, how indeterminate test results are handled. You need to show blinding, which we're going to talk about. You need to have a flow diagram that demonstrates exactly how the patients have moved through the study and when each of the index and the reference tests are performed in terms of timing. What you should always do, and this is actually something you should practice when you're reading papers, is to create your own 2x2 table. You'd be surprised how much you can enhance your own understanding of what was done in a research manuscript by making your own 2x2 table. even if they have a 2x2 table in the study, that's figure 2, I would encourage you to make your own. More than once, I've found at least inconsistencies and mistakes in manuscripts based on what they describe in the results body of the text and what they're depicting in their figures. And so this really helps for you to kind of understand the performance characteristics. You can create your own likelihood ratios. And if they report their actual data, you can actually do your own sensitivity analyses and take out certain patients and then redo a 2x2 table. You'd be surprised what you find when you do that. I'd really encourage you to do that. So here we're going to talk about a few different studies that were comparison studies. So this was using point of care ultrasound and comparing it to some other modality of diagnostic testing. This is one of the sentinel papers in point of care ultrasound in emergency medicine. It's Diku Mandavia from USC LA County. I believe it was published in 2001. And so what they were doing was trying to see how well they could identify pericardial patients with pericardial effusions with point of care ultrasound. And they were comparing it to the gold standard of the echo lab. And so their table 2 is right here. They actually called it table 2. And there's a lot of takeaway points. This is a really important study. But 20% of these patients that they identified in table 1 as being at risk for pericardial effusions actually had them. And lo and behold, they found them with sensitivity and specificity that was more than comparable to the echocardiography lab. There were very, very few discrepancies. However, my question is, what happens to these patients? And so this is a really great example of a study that is hypothesis generating that we never really followed through on the hypothesis. And if you set up your ultrasound research group in such a way that you can follow through on these patients, then you can take something like this and take it to the next level and make it outcome oriented, which is what we would all really want to know. 1 out of 5 of these patients had pericardial effusions. That struck me when I first saw that, but what happened to them? Was it important to find these? We really can't know unless we replicate the study. This is really crucial when you're talking about point of care ultrasound research. So this is one of the reporting guidelines in the STARD criteria. It's test heterogeneity. And so this is a really famous study, care ultrasound. It's from CRISP, Lovato, and Timothy Jang. It's the 2-point compression sonography for DVT study that they published in around the 2010, I believe. I was in residency, I do remember that. And so what they did here was they created a figure where they depicted the number of study patients that each study team member enrolled. And so this is critical because what you see when you look at a table like this, over half of the study team members only enrolled 1 or 2 patients. And if you don't present this data, then the reviewers or the readers are left to wonder, team of let's say 24 physicians, but really, was this all just done by the lead investigator? And then suddenly what you're left with, this isn't really a diagnostic testing research. This is just a demonstration of one person's skills in one area of diagnostic testing. This is critical. This is going to cure manuscript when you get into the review stage. This will impact your grant application. These are things that skilled researchers are going to pick up right away. Anyone who's familiar with the STARD criteria will know that this is a reporting guideline that you need to be prospectively commenting on in your grants and in your manuscripts. Blinding is critical. Timing and blinding anytime you're doing diagnostic accuracy studies is mission critical. If you've ever done any systematic reviews and meta-analysis and looked at the QUADS 2 criteria, or if you're familiar with the STARD guidelines, they talk about this ad nauseum because the interpretation of one test may depend on what the interpreter knows about the other test or about the patient themselves. So ideally, the person interpreting the reference standard has no knowledge of the comparison standard of the index test and has no knowledge of the patient's clinical criteria or any clinical data. In point of care ultrasound, this is extremely, extremely challenging. It's the bane and the benefit of point of care ultrasound. So with POCUS, one of the best parts about it is the person performing it is a physician and that they actually have the clinical context, right? You've seen the radiology reports that almost invariably end in clinically correlate. Well, point of care ultrasound is clinically correlated. It's part of the definition of point of care ultrasound that it is a clinically correlated study. So how do you blind the person doing the POCUS exam to the clinical criteria? You really don't. And so in this study, they were able to get around blinding to the CT and the abdominal X-ray, which were the comparison standards, by mandating that POCUS was performed prior to the other imaging studies. So that was done, and that was done well for all of the patients. But they mentioned, and it's obvious if you read through it, you can't blind somebody to what's actually happening with the patient. And so if the physician sonographer goes in to do an abdominal ultrasound exam, and someone's got a firm distended abdomen and is vomiting, the oral contrast the radiology department made them choke down, that person is going to be more likely to have a true SBO than say someone who's kind of narked out on opiates, whose belly is not distended, who probably just has an ileus or maybe even just constipation. And so there's very little ways around that in the clinical setting. One of the ways they got around it in this study was to create an artificial environment. And so this was a study to evaluate the accuracy of point of care ultrasound to confirm endotracheal tube placement. So what did they do? They brought the technology to outpatient surgery, and they set up a curtain between the sonographer and the anesthetist. And so the anesthetist would pull a card that would tell them to place the ET tube into the trachea or the esophagus. And then as soon as it was placed, they hit a button that turned on a light, and the sonographer would then start the scan of the neck and then make a determination of whether the tube was in the esophagus or the trachea. So this study had perfect blinding, perfect sequencing and timing, perfect blinding, and it was 100% sensitive and specific. Anybody see what the problem is here? The problem is that this is an in vitro setting. This is not an in vivo experiment. And so this is a constant balance in point of care ultrasound research that we're trying to make it as real world and pragmatic as possible. But from like an experimental design standpoint, that can prove to be hard to impossible without creating these artificial environments like they did in this study. One of the biggest advantages of point of care ultrasound research is the ability to conduct a serial exam. The article I have highlighted here was from Critical Care Medicine or Critical Ultrasound Journal in 2017, looking at combined IVC and lung ultrasound and admitted patients with heart failure. And so they were looking at markers of decongestion. And their assumption here, their hypothesis, was that urine output and dyspnea are going to lag behind the changes that happen on imaging. And maybe we could tailor our diuretic strategy towards imaging. We might be able to make more accurate disposition decisions and maybe even more timely. But when you're talking about serial exams, it becomes very difficult for the statisticians, because what you end up with is a ton of data, the same data at multiple different time points. And then the statisticians need to figure out how they're going to interpret that data. Are they going to look at the raw scores? Or are they going to look at the change scores? And if you were to measure the deltas, it opens up this whole new can of worms in terms of the analysis side. It's not impossible. It's just something that needs to result in an early conversation between the clinical team and the statisticians so that you can get this right, so that you're not caught, with your pants down at the end of the study, that you have all this data and then no one knows what to do with it. And if you had done one or two things differently, you might have ended up with a lot more methodologically sound research. I hope you're all pretty familiar with this project or this study. This is the study from New England in 2013, looking at ultrasound versus CT in suspected nephrolithiasis. This is probably the most robust randomized trial performed in point of care ultrasound to date, at least in my opinion. And so what did they do here that was really interesting from a research design standpoint was that they made the primary outcomes about safety. And so making the primary outcomes about safety allowed them to seek out the most appropriate funding source, which in this study happened to be AHRQ. And it was a huge multiple $million-dollar grant. This was a multi-center study that happened all across the country. And they were able to tap into that research, into those research dollars because of the way they structured their primary endpoints. The secondary endpoints were centered around diagnostic accuracy of the various modalities and a lot of other software endpoints. But they did an excellent job of focusing on safety, knowing that safety talks, and that they were able to match this with a funding source that had a lot of money to give, quite frankly. This is a study that received no money on this study. But what we did here that was really neat was that we had taught the nurses at one of our hospitals an ultrasound guided peripheral IV procedure. And so we had built this program that started with just 2 nurses and then grew to include over a dozen nurses in that department. And we structured the program so that it could be self-sustaining, so that the 2 nurse leads were the primary educators and we became supplemental educators, which took some of the kind of the primary work off our plate. And then number 2, we set up the reporting database that completed, all the data was entered by the nurses. And we set it up in such a way that we could mine it for research. And so we've published about 3 posters and abstracts and 2 manuscripts out of this study. The downside to that is really only for me. I am contacted by the Journal of Emergency Nursing anytime they have an ultrasound manuscript, anytime. I probably get 2 emails a week from them. So be careful what you wish for, but apparently right now as it stands, I am the content expert, the one and only for that journal. This study looked at another outcome, and this was more of like a prognostication outcome. And so this is the blush failure trial, which we participated in. And so the reason I bring it up here is because you're able to use, we were able to leverage a bunch of the things I was talking about to make this happen. So this leveraged an existing heart failure research network called MROC, which was Indiana University, Wayne State, and Vanderbilt. So a lot of the kind of operational side of things was just plug and play. We were taking a different study protocol and plugging it into an existing research network. And then the other thing we did here was that we were able to make this an intervention trial, because even though we had developed this complicated algorithm, which basically involved scanning and rescanning heart failure patients, quantifying the number of B lines, and then tailoring diuretic therapy to that, it involved work on the physician side, because we had spent months training select research nurses and research associates how to do the lung ultrasound exams. And so that allowed this to be a really robust randomized trial that was an intervention trial. And so this is another existing research network that we can tap into. This is the Siren network. This is the follow-up to the NET. I don't know if any of you remember the NET, the Neurologic Emergency Treatment Trial, which is an NIH-funded network. And so the Siren has a lot of projects ongoing. One of them that's ongoing is IceCap, which is a study of the efficacy of various durations of cooling in cardiac arrest. And so the beauty of this is these are massive research networks with a huge infrastructure that are already funded and collecting tons of data. And all you need to do to participate is come up with some sort of ancillary project that can leverage the data and leverage the main project itself. And so what we did is we are collecting the echoes that are done on these post-cardiac arrest patients. And then we're going to do some offline analysis on the echoes to look for signals of prediction of malignant arrhythmias in the rewarming period. And so this really requires just an idea, some time, and some effort to find a small amount of funding to complete your project. But all of the main work of the project is going to be done by the research teams in the various Siren hubs. Most people who have done point of care ultrasound research quickly realize that most of the projects that you want to do, they require you and you only to acquire the data and do the ultrasound exams. And that becomes really tiresome and really onerous. And so this is a great way to get other people to help you acquire the data. And then you can kind of stay at the top of the food chain and be the idea person and truly the principal investigator who's in charge of everything, but not fully responsible for the primary data collection. Patient experience is another element of outcomes research that point of care ultrasound has started to delve into. So there's a couple studies I'm going to present here. One of them's from Mass General a few years ago, and this was just simply a survey. It was a survey that they had given to patients in the ED at the same shift at the same time, but half of those patients had had point of care ultrasound as part of their care and half of them hadn't. And so they did this on various days over a year, and then they collected the data on the responses to the patient satisfaction surveys. And they found small but consistent and statistically meaningful increases in pretty much all of the various markers of patient satisfaction that they measured in the patients that had had POCUS as part of their emergency department care. This is a study from UC Irvine, Chris Fox's group. There looked at the effect of pelvic ultrasound, point-of-care pelvic ultrasound on length of stay in their ED. And so this is what they found. This is a huge difference, and this is over an hour. Basically found an 80-minute reduction in length of stay in patients who underwent a point-of-care ultrasound strategy for imaging versus radiology. And one thing that's even really important to consider with this project is that this is done at a relatively smaller volume, high resource academic medical center. And if you extrapolate this to the busy county style, low resource academic medical center, the magnitude of this difference is likely much larger. I can speak from personal experience where I work at Sinai Grace. We are a high volume, lower resource medical center. And it is way more than 87 minutes on average if we were to study that. So this is nice to show the people who care about these sorts of things, like the patient experience folks at your hospital, that POCUS is a part of the solution and it's not a hindrance to patient satisfaction. I'm gonna just kind of skip over this in the interest of time, but feasibility used to be something that was really easy to study and really easy to publish on. But now as medical education research has become more mature, if you're gonna try to drop feasibility into your primary outcome of a study or as aim one in your grant application, be very, very careful. Feasibility isn't just like a thing, like, oh, we were able to complete the project, so therefore it was feasible. That's not how feasibility works. Feasibility actually has 8 separate domains that fall under it, each of which has its own definition. And so I highlighted the ones that I think are probably the easiest to study in point-of-care ultrasound, but I urge caution. Just be very, very careful if you're going to try to do something and claim it to be feasible simply because you were able to do it. Medical education research is a burgeoning subspecialty of research in emergency medicine. I think it's an area that's ripe. We've utilized our fellows to produce quite a decent volume of point-of-care ultrasound research in the med ed realm. I would encourage you to use this as a way to garner favor with your department chair. Because if you look at the novel study populations that I highlighted here, that's not an exhaustive list. You have other departments in the hospital that are asking for your help all the time in teaching. I mean, if I'm wrong about that, correct me, but I don't think that I am. I must get an email every week from some department in the hospital asking us to teach them something about point-of-care ultrasound. Most of the time, you're not going to get paid for that. There's not going to be a direct compensation. So a great way to get indirect compensation and personal gain for your department and for your faculty is to create a research template so that every time you take your stuff to another department, to another learner population, you're able to generate some data, which you can then use to publish. And that's a great way to make your chair happy, to make everybody happy. Your ultrasound faculty CVs will grow, your department chair will have more people up for promotion, and the other departments are gaining benefit because you're coming in and teaching them for free. So the next key element that we're going to talk about before we get into some examples is how to create a really great POCUS study team. I almost got rid of the picture on this slide, given the feckless nature of the University of Michigan's football team as we speak. But I am true blue. I've been a fan for life, so I kept it in. But here I have listed the various team members that you will likely consider engaging in point-of-care ultrasound research. And I loosely ordered it based on what I feel to be the most important to the least important people. And we'll kind of go through each of these. This guy here was actually a fellow of ours. He looks like he's out of a movie. But he was really a fellow of ours at Wayne State about 5 years ago. He moonlights in Alaska. He actually travels up there every other month and he does 2-week shifts. And so this was after he graduated and he took some of our faculty up for a trip to Alaska. And this is him showing up at the docks to take them on to some boating trip in the middle of the ocean. So the fellows, I think, if you do have a fellowship, are probably the most reliable and probably the most important part of your study team. Research is going to be a big part of their year with you. It might even be more than 1 year if you're combining fellowships. I know there's a lot of fellowships that are now combining research and ultrasound or med ed and ultrasound that are helping the fellows obtain formal graduate degrees, and that's great. But most of the time we only have 1 year. So it's really important to plan early. And we sort of have a quid quo pro approach, and we have our fellows develop a project of their own. Obviously, we coach them a lot through it. And if they have some idea that they think is the greatest idea in the world, but it's just simply not compatible with the environment and resources that we offer, we do massage them into the direction that we think is going to be most productive for not only them, but for us too. But we also plug them into existing projects. And so these could be, years long projects where enrolling patients is really challenging, or it could be some brief retrospective data mining project. But that's how we approach our fellows. And sometimes those projects result in what we call the fellow research relay, where one fellow's project, which seemed like it was could be completed within a year, was not able to be completed. So that gets passed off to the next fellow as part of this is the one we want you to do, and now you're going to have to come up with one on your own. But I would really encourage you to plan early. If you wait till July, it'll be almost impossible to get something done. Your faculty is the next most important part. I honestly think the most important thing is to have a separation of church and state. And so what I mean by that is, I think the critical mass of ultrasound faculty to start to do effective research is 3. What that does is it allows one person to focus on education, one person to focus on research, and one person to focus on the admin, operation, hospital relations, and billing side of things. Once you can get that critical mass of 3, I really do think it can take off. And everybody's going to help everybody, obviously, but having one person whose job it is to produce quality research and to get other people published, I think is just absolutely critical. Getting department chair buy-in is obviously important. And like I said, I think one of the strategies where you can utilize this structure to get department chair buy-in is the educational offerings to other places in the hospital. If you can do that, that's going to make your department chair super happy. It's really important to massage that relationship and to understand what is it that your department chair wants to make him or her look good in the eyes of the School of Medicine. And then figure out how you can help your department chair achieve that. That is going to be the biggest win possible for you. And with the explosion of education in the undergraduate medical education realm, that's an obvious one for a lot of places. But it does also put a lot of strain on your numbers. So sometimes the research side of things can be much more helpful for your chair. Your chair wants people to be promoted. And if you can be somebody in point of care ultrasound who can get promoted quickly, that's going to make your chair very happy. We have a research think tank where basically anytime our ultrasound faculty want to engage in a research project, they have to present it to our department's research division, which hosts a think tank meeting every month. If I could replay the Mr. T clip right now, I would replay it, because presenting a point of care ultrasound research project to a bunch of old curmudgeons who don't really know much about point of care ultrasound, but know a lot about research, is really quite painful. We've had a lot of counseling and emotional support we've had to provide faculty after these sessions, but invariably they all find them very helpful. It is invaluable to get non-POCUS eyes on your project early. Because like I said, we're kind of like evangelists at times. We all speak the same language. We all believe in the same thing. And so when you're pitching a project to someone who's in the point of care ultrasound club, they're likely to have a warm reception to it. Unless it's something they're also wanting to do, and then they're upset that you're beating them to the punch. but usually they're going to have a pretty warm reception. But getting the input of non-POCUS people is mission critical to successful research. No, this med student was not injured by point of care ultrasound. This was a pre-existing condition that he had before this event that we hosted. This is a Sono Cup event that we host. It's kind of a fun, interactive There's a lot of side benefits to having these sorts of events. One of them is get med students thinking you guys are the cool kids on the block. And so how that benefits you is the med students, a lot of them are going to apply to specialties that are quite challenging to get matched into. And so they know they need to do research. And so they're going to come to people who they know are doing research, who they don't find to be intimidating. And so if you can do a fun event like this, it allows you to present yourself in a way that you're very much an expert in this area. And you are very much approachable. You're a normal person. You're able to have fun. And a lot of the problems with a lot of the traditional research kind of thoughts and approaches are that someone is so narrow and so deep that it's not even approachable for someone who's brand new and may not really want to do research, but has to do research, or someone who just simply wants to. And so the med students, I think, are just a fantastic source. Most of them have a summer off between first and second year. A lot of them have a lot of elective time in their fourth year. And so if you're at a place where you have a point of care ultrasound program in the med school, that first year summer sort of externship can be the intro to your group where they help you with some data mining type projects or data entry, and you sort of feel them out for what they want. They go, they do their clinicals, and then they come back in the fourth year to do a research elective. And now they can actually do ultrasound and enroll patients. And it's really a win-win for everybody. Research assistants are a huge source of benefit, but you do have to remember that in most departments, you won't have access to your research assistants unless your study has funding. And so we'll talk in a little bit about how we can try to get funding, but this is the algorithm for the blushed heart failure study that we had that basically relied on our research assistants to do the actual point of care ultrasound exams. And we were even able to publish the training that we did with them in posters. And so that was a win-win-win. The people who designed the trial won because they could come up with a complicated intervention trial that once the patients were enrolled, it could really be run by the research assistants. The most important point with the biostatisticians is to get them involved early. They don't speak the point of care ultrasound language. So if you're going to use point of care ultrasound for data, you really need to get them involved early. Before you talk to them, it would be really, really helpful to have some sort of estimate in your head of the effect size of what you're trying to do. So let's say you're looking at pneumothorax and ultrasound guided central line placement. Well, what's the base rate of pneumothorax? That's something you should need to know. And then what do you think your effect is going to be on that base rate of that condition that you're studying with the intervention that you're proposing? You don't have to be perfect, and you might have a range. And then your statistician can help you with that range. And what they'll kind of explain to you is how you can sort of manipulate the range to get you to a sample size that's manageable. But if you don't have this information before you talk to them, it's not going to be a great productive conversation. And absolutely don't go to them after you've completed a project and you have all this data and you have no idea what to do with it. Please don't do that. Mentors are important. I am going to go through this quickly so we can get into our examples, but these are the 4 different types of mentors in my opinion. This is just simply based on the way I see the world. There's inspirational, operational, there's confidants, and then there's opportunity generators. I think it's important that you have more than one mentor and that they touch on each of these domains. Some of them might touch on more than one of them. That's great. But you should have someone in each of these domains. Buyer beware when it comes to residents. And this isn't to knock residents at all, but they are busy people. They are working on becoming clinical superstars. They probably are not the best study team member most of the time. If you do get residents, I would say starting early, getting them as PGY1s, or if it's third years, you're going to get people who are going to fellowships that have very concrete goals they want to get out of the research experience. One strategy we used in the last couple of years was to get everybody city trained and to get them onto the key personnel forms for all of the ultrasound studies as soon as they started residency, so that when they did ultrasound rotations, if they came across potential study patients, then they could participate in the enrollment, consent, and actual ultrasound exam of that patient. When you're applying for grants, it's really important to consider what you are. Are you point of care ultrasound centered, associated, or as an adjunct? And what you are may not be what you present yourself as, because you need to consider the reviewer and you need to consider the funder. The funder is going to be looking for low risk, low reward research. And so it might be that if you kind of pitch point of care ultrasound as an adjunct and center it around a more traditional endpoint, maybe one involving safety, it may be more favorable to the grant, to the funding source. When in reality, what you want to do, your project is really point of care ultrasound centered, but that would be something that may not be found favorable by the funding source. And so you really do need to consider your funding source. Read the mission statement of the foundation or the organization that you're applying to, and then figure out how we make point of care ultrasound a part of the project. It might not be front and center as it's presented in the grant. The most important part of applying for a grant is to have preliminary data. There are two important elements of a grant review. It's the investigator and the preliminary data. Once you've hit submit on the grant, you can't do anything about either one. But you should always be thinking about ways to make you a better investigator or a more attractive investigator and to acquire preliminary data. So in this realm, QPath can be our friend. If you structure your own department archive or QPath in a way that makes it easy to mine for research data, then you're always on the cusp of preliminary data. If you come across some idea that's novel to you, you at least have some sort of framework that you can look into and say, hey, do we already have some preliminary data, or do I need to spend the next 6 months collecting preliminary data, which then puts you a year behind in applying for a grant. And if it's a competitive grant application, the ship might have sailed at that point. So unpublished data is fine. If it's your own data from your own archives and you've done your own analyses on it, but it's not been published, that's fine. That counts. That's still preliminary data. Published is better, but unpublished still counts. So when then you get into the grant stage, what are your reviewers going to critique you on? The number one thing here is convenient sampling. And this is really, really hard to get around. You can't be there all the time. Like, you know, I feel like sometimes the other faculty at my shop think like I'm like the EKG machine. I'm just always there. Well, you can't be there all the time. So inevitably, every point of care ultrasound project is going to fall victim to some form of convenient sampling. You have to go into the process knowing that that's the case, and you have to figure out a way to wordsmith around it or to set up your project or your grant so that you're demonstrating that although we've enrolled a convenient sample here, we've done a comparison to an unselected random sample from some time frame, and these patients are exactly the same. We haven't cherry picked. We might have only enrolled patients when it was convenient, but we did not cherry pick. Convenient sampling is code for cherry picking. And so you really do have to go into the process knowing that that's what they're going to be looking for. And you have to figure out how you're going to get around that. It can either be through careful wordsmithing in the grant, but more appropriately, you should do some sort of analysis with some random sample of patients with the same condition. These are the other things that are going to come up, but convenient sampling is the big one. So let's get into a couple project ideas. I think we have about 5 minutes left. So I have 3 separate ideas. The first one is TEE and cardiac arrest. Everybody loves TEE and cardiac arrest. It's like the new hotness in emergency medicine. It's really easy to get a manuscript published in TEE and cardiac arrest. You basically just have to write about it and show a picture and someone will publish it somewhere. So some junior researcher comes up to me and says that they think performing TE during cardiac arrest will lead to improved outcomes. That's their idea, and they're looking for me for help as to what to do next. So I present them with two options. Option one is the slow build, and option two is the fast track. So let's do option one. What's that entail? So we're going to review our institutional data. We're going to look through QPath. We're going to talk to our anesthesia ICU colleagues. We're going to collaborate. We're going to talk to our EMS colleagues. We're going to look at their out-of-hospital cardiac arrest registry. And as we do all that, we will realize publication opportunities before we ever turn on an ultrasound machine. Option two, you have this great idea. You're an awesome writer. You're super smart. So you just go ahead and apply for a grant. The problem is you have no preliminary data. You've never trialed the protocol. So in the anticipated problem section of your grant, you're just shooting from the hip. It'll be very sparse because you don't anticipate any problems because your idea is great, you're great, your equipment's great, and everything's great. You have no estimated effect size. You have no outcomes really, because you just said patients will do better, but you haven't really elaborated on that. And you have no idea what the potential barriers are. So the option one people did this, and what did they come up with? They were looking at different outcomes, and along the way of looking at the internal data, they noticed this degree of RV dysfunction that a lot of the patients had, but some of them didn't. So what did they do with that? They found 24 patients that had TEs in the last 2 years. 75% of them had RV dysfunction, but the ones who didn't, every one of them survived. So then they wrote a research letter to the editor, described their findings, became the first person to publish on this realm in point of care TEE to date. And they laid the groundwork for their grant application by improving the biggest weaknesses: no preliminary data and unproven investigator. They were able to kill two birds with one stone, and they use RV dysfunction as aim one because they've now published about it. This is now in the scientific literature and it's preliminary data that's useful. And they use their other aims to do the things that they actually wanted to do when they met with me in the first place. The next person comes in the office and has an idea that they want to determine the accuracy of point of care ultrasound to diagnose acute appendicitis in pediatric patients. And that's a great idea. I applauded them and then said, I think it's time for you to do a literature search. And so they did a literature search, and what did they find? Well, they found this. This was a systematic review and meta-analysis from 2017 that was published in Academic Emergency Medicine. It's a brief 24-page manuscript with seemingly an endless amount of figures and tables. It was really well done. And so they were like, crap, well, I guess I can't do anything. Well, I gave them two choices. I said, half of systematic reviews and meta-analyses are updated within 3.5 years anyway. So maybe this is time for an update. But maybe we can look at the actual manuscripts and see how we can do something differently. So that's what we did. And we found that a lot of these manuscripts involved EM attendings, PEDS EM attendings, PEDS EM attendings, residents, faculty. They were brief trainings. So it was like 5 supervised exams, a lecture, a hands-on practice session. So what did we do? We came up with a way to study medical students. And so we used the advanced EM POCUS elective to create a prospective study where we would actually study it using medical students performing it in the PEDS ED. And then we started meeting with a biostatistician and a librarian, and we planned to update the systematic review and meta-analysis. We were able to involve the non-ultrasound faculty, and we were able to involve some residents in the case. So that made our department chair super happy. The last project here was one of our fellows from last year had an idea about fascia iliaca blocks in hip fractures, and she thought the addition of a steroid cocktail to the local anesthetic would improve analgesia for these patients. So that was her idea. I want to do a randomized controlled trial with steroids versus no steroids. However, we did a lit review and found there was a Cochrane review on the same topic from 2017. And this one's pretty definitive. So the addition of dexamethasone did prolong anesthesia time by about 6.5 hours. So what's next? Well, we looked at our own preliminary data in QPath. We found 22 patients with femur fractures that got fascia iliaca blocks and about 180 that didn't. And then we looked at the discharge medications, and we were able to actually tap into the pharmacy database and figure out how many morphine equivalents these patients used over 30 days. And the difference was dramatic. So we published the retrospective data in a poster, and then we came up with a new idea for a randomized controlled trial of blocks versus no blocks. We were very collaborative, And we came up with a clinically oriented, patient-oriented endpoint that block patients would consume smaller quantities of morphine equivalents over 30 days. This is now an extremely fundable study. The prior study, not so fundable, but this is extremely fundable. Reducing opiate consumption is a very hot topic in all of medicine, not just the House of Emergency Medicine. So we opened up all the doors to these different funders, and we're currently enrolling in a funded project for this. Blue Cross Blue Shield in Michigan funded us, and although we had to pause for COVID, we've recently resumed enrollment. So that was a lot. That was a whirlwind of point-of-care ultrasound research. I hope you learned something, but I do have some parting words. I think you really need to structure your team with research in mind, even if you're not a research-oriented point-of-care ultrasound division. If you structure your team and assign your roles so that you're always thinking about how this can help us produce research, then the research gets a lot easier. You've lowered the activation energy to do some of these low-hanging projects. You need to really match your team and your questions really well. Not every POCUS team is going to be suited to study every POCUS question. It doesn't mean that you're bad researchers, bad sonographers, or bad doctors if you're not suited to study advanced echocardiography. It just means it's a poor fit. It's like an option football team trying to run and spread, run and shoot offense. It's just not a good fit. Listen to your non-point of care ultrasound people. They have invaluable insights. Even though you're doing ultrasound research, always think about your clinically oriented, patient-oriented endpoints. That's going to make you most appealing to funders. Safety sells to funders. Diagnostic accuracy studies don't. Big funding organizations don't care that EM ultrasound sonographers are just as good as radiologists at identifying cholecystitis. Try to tap into some regional networks. Be the person that helps to create them. Collaborate with your non-POCUS people and don't get discouraged. So I hope at the end of this that we're celebrating just like the Lions here. The Lions are actually celebrating a touchdown that their opponent scored against them. But all celebrations are worthwhile. So I hope you're celebrating in one fashion or another at the end of the lecture today. Thank you.
All right, thank you, Dr. Favot, for this very informative presentation. I would like to open it up for discussion at this time. As a reminder, you can enter your question in the chat box or unmute yourself to ask your question at this time. Dr. Favot, it looks like we only have one remaining person on the session, so I'll just give it 30 seconds and see if that person has a question. And I would say at this point, probably not. So thank you again for this presentation. And thank you to everyone who was able to attend. Have a great day.
All righty. Thanks, everyone. Bye.